Oh, hold on, I gotta press something. Thank you all for coming. As a reminder, during our session, if you have questions for the speaker, to use the Q&A function that allows you to ask the question, and then at the end of the talk, we'll go ahead and have a Q&A session where we ask questions, and then Latanya will answer these. I'm going to introduce Amy Bailey, who is going to introduce our speaker. So Amy, why don't you go ahead and take it away?
Great. Let's see. Am I muted still? No, I am not. Fantastic. Hello, everyone. Thank you so much for inviting me to introduce today one of the newest members of the CSDE family, Professor Latanya Trotter. Professor Trotter joined the faculty of the University of Washington School of Medicine's Department of Bioethics and Humanities this fall as a tenured associate professor. Prior to this, she was on faculty in the Department of Sociology at Vanderbilt. She earned her master's and PhD in sociology at Princeton, and also a master's of public health from the University of Washington. She publishes widely on issues of health professions, the structure of the healthcare system in the United States. And her book, More Than Medicine, was published by Cornell University Press. Her work has been widely lauded, and she's received awards from APHA, SSSP, the American Sociological Association. She's on the editorial boards of Gender and Society and Contemporary Sociology. And today is going to present When the Safety Net is a Nurse, Organizational Care Work in the Context of State Retrenchment. So welcome, Professor Trotter.
Well, thank you, Amy, for that generous introduction, and to Sarah Karan and the CSDE for the invitation to come and speak today. So what I'm going to share in the next few moments are some of the key insights from my book, More Than Medicine. But I want to begin and end with some thoughts from a current study I'm working on that centers the work of nurses during the pandemic. And although this new work is based on different empirical evidence, it is analytically a continuation of the ideas that I first developed in the book, which is another way of saying, after the book came out, I did keep thinking. Let's see. So let's start with the new study. So the Caring in Crisis study, I've collected about 80 interviews from US registered nurses from a variety of settings, asking them to talk about their experiences doing nursing work during the pandemic. So I'm still making sense of these interviews, but I want to spend a moment on one kind of experience that has emerged from these 80 conversations. So I want you to hear the words of a nurse who I'll call Carol, who worked directly with COVID patients at an acute care hospital. Carol, like many nurses, recounted her experience with changes in hospital procedures, about the new skill of donning and doffing PPE, of how particularly during the first wave, there were seemingly constant pronouncements and amendments to how she was supposed to do her work. But one of the things that struck me was how new infection control policies reshaped the geographies of care. So for patients with COVID, one of the ways one lowers risk to workers is by limiting their exposure. So PPE and other barriers are one method of doing so, but limiting who goes in the room is another, which meant that in many cases, the nurse was the one in the room. So when Carol described what that meant during the first wave, she noted that because everyone else was encouraged not to go in the room, quote, "We nurses did everything. We transported our own patients. We cleaned the rooms, trashed out our own rooms. We changed the linens. We ran everything." I mean, literally, the only people going into rooms for a while were the respiratory therapists and then us. Like, I remember reading the attendings notes about how they cared for the patient and examined the patient. And I'm like, your entire examination is based on what I told you because you never went in that room. So being the one in the room had consequences beyond the additional work. It meant that sometimes the words of the nurse were the deciding factor in whether to change the level of care, such as whether to transfer someone to the ICU or not. So the doc, of course, is the one that makes the decision. But when no one else is in the room, some nurses found themselves in the position of choosing whether a decision needed to be made. So another nurse, who I'll call Jackie, relayed a story of a patient death that continues to haunt her. So this was early in the pandemic. The patient seemed stable. They were talking, they were joking. They kept saying that they felt fine and they wanted to go home. So what Jackie didn't know and couldn't know, because no one knew much about the course of the disease at that point, was that patients often did feel fine, showing no signs of respiratory distress, right before they took a sudden turn for the worse and died almost without warning. So I've chosen to share the stories of Carol and Jackie, not because they are representative. As you can imagine, when one casts a net that contains every state and every healthcare setting, the result is tremendous variation. But I chose to highlight these stories because they're illustrative. Both experiences illustrate something that I think is important to take seriously, which is that in the US, nurses have taken on the structural, professional, and existential position of being the one in the room, which often puts them in the position of doing a broader scope of work and making a wider set of decisions than most folk, including academic folks, seem to be willing to take into account. Given how little they are studied by academics, you might be surprised to know that there are almost 3 million registered nurses currently working in the US. So there may be only one of many kinds of healthcare workers, but there sure are a lot of them. And analytically, if you had to choose a point of view through which to understand how healthcare works, more academics than currently do should consider seeing the world from the perspective of the nurse, because they are the ones in the room when physicians are present and when they are not, when family is present and when they are not. And also, unlike many others who provide direct patient care without an RN license, like CNAs or home healthcare aides, they are often in the rooms where decisions are made. So nurses may not always have as much power as they would like, but they are often in the room when power moves. So as I move into the main part of my talk, I want you to consider, as I did, what one might differently know if one looks at the world of healthcare from the perspective of the nurse in the room. Because as I continue to do so, I'm finding that the kinds of urgent and evocative stories coming out of the pandemic are in fact reflective of long-standing, even routine problems that healthcare organizations and their workers faced prior to the pandemic. Because the crux of my argument is this: before, during, and eventually after the pandemic, US nurses will not only be tasked with performing the visible work of caring for patients. As the ones positioned in the room, they are often the ones charged with the invisible work of shoring up a healthcare system crumbling under the weight of social inequality. So in my talk today, I suggest that it is through standing alongside nurses and paying attention to that less visible work that we can more clearly see the normalized state of crisis in which our healthcare system functions. And through attention to that crisis, we can re-see the constraints of nursing work as one thread in a larger project of misrecognition that obscures and normalizes gender and racial inequality, both inside and outside the medical workplace. So I did this work of reseeing in a site far removed from the pandemic, or even the hospital where most nurses work. I did this work in an outpatient clinic where I observed the everyday labor of nurse practitioners. So for those who don't know, nurse practitioners are registered nurses who have obtained additional education and a license, which allows them to make the kind of diagnostic and treatment decisions that were once the exclusive province of physicians. And the right of NPs to make those decisions has been as much a political as a regulatory matter. So here you can see the landscape of NP practice autonomy. The 23 states in green indicate those in which NPs can diagnose and provide treatment without physician oversight. So what's not visible on this map are the legislative battles through which this right was won. But the nurse practitioner isn't just a site for understanding professional conflict or for recounting the strategies that they use to secure such wins. It's a case through which we can understand nursing's particular relationship to social inequality. Because the creation of the nurse practitioner was not a declaration of nursing's autonomy, but a declaration of its utility. So the NP came into existence in the mid-1960s, which was also the same moment when several healthcare crises were coming to the fore. Right? We had the demographic bump from the baby boom, which increased precipitously the demand for primary care. We had the passage of Medicare and Medicaid, which increased the numbers of insured people seeking medical care, particularly older adults, those with disabilities, and those living in poverty. So this increased demand was really quite unfortunately timed, because this was also a moment in which physicians were discovering the rewards of specialization, which not only took them out of the primary care pool, but the higher price of specialty care became an independent factor in rising costs. The nurse practitioner then was explicitly put forward to address all of these problems, right? So the profession did not make a claim for nursing specific expertise, because in order to be useful in solving all of these problems, nursing had to argue not that it offered something different than professional medicine, but something similar or indistinguishable from it. And it's partly a measure of their success in making this case that explains the spread of nurse practitioner autonomy. But it's important to remember to whom nursing had to make that case. Not to individual patients, but to the state. So traditionally, scholars of the medical workplace have not focused on appeals to the state because their gaze was aimed squarely at the physician, right? And professional medicine, as an iconic profession, obtained and maintains the right to govern itself, which is another way of saying they've been able to maintain themselves relatively free from the meddling of the state. But for scholars who study the experience of women in the labor market, they've critiqued this understanding of professional attainment. And the core of that critique rests on the observation that our theories of professionalization are gender neutral in a world which is fundamentally shaped by gender. So scholars like Ann Witz and Ivy Brajat argue that in order to really understand the professional projects of women, it really requires us to reconsider neglected actors such as the state. Because without access to foundations, the higher education system, and political networks, women have historically relied on gendered appeals of utility and moral authority directly aimed at the state. So just as these appeals are not gender neutral, they are also not race neutral. Right? So the moral authority that legitimated nursing's entry into healthcare was explicitly a white, middle-class construction of benevolent womanhood. And in the case of nursing, these appeals were not just made to the state, they were made directly to healthcare organizations, right? So in the early 20th century, nursing was successful at convincing hospital administrators that it could meet the hospital's growing demand for a skilled, cheap, and pliant workforce. Because unlike the enduring model of physician consultancy, it is still organizations, not individual patients, who engage nursing labor. So nursing's climb up the occupational ladder has largely been achieved through its responsiveness to the material and moral obligations of their employers and the state. Which is why in my own work, I considered not just relationships among providers, but those between providers, their employers, and the state. So my book, More Than Medicine, centers 17 months of field work at an outpatient geriatric practice, where I observed how interdisciplinary teams of providers, which included, among others, NPs, but also physicians and social workers, how this team cared for medically and socially vulnerable older adults. I paid attention not only to how each provider carried out their work, but what kinds of problems and whose that work seemed to solve. The team model of care was really central to my analysis, because although I came to the site interested in the work of the NP, I was really interested in that work as negotiated with and by other providers. So the NP, in effect, served for me as a kind of diagnostic lever through which I could understand the broader logics that structured the work that happened. And it wasn't paying attention to this collective work that I came to my primary findings. So although the grounding argument for NP utility is that of substitution, when I paid attention to what NPs actually do, what I found was the performance of difference. In the book, I describe how these nurse practitioners address a broad array of social, family, and economic problems through what I call clinic work. And in the book, I make the case that the NP's performance of clinic work was an organizationally situated form of care work that was different than the medical work performed by their physician colleagues. And what is care work, right? So there's lots of working definitions of care work, but really what fundamentally distinguishes it from other forms of labor is how it is performed and who performs it. So care work is relational, right? It's based less on discrete services than on a general responsiveness to the needs of a person. So this sort of relational feature of the work can't be separated from the fact that it overlaps with labor historically performed by women. So I observed that instead of merely acting like physicians, these NPs endeavored to act like nurses. And in doing so, they made visible that patients were suffering as much from a scarcity of care work labor as of medical labor. And embedded within this expansive notion of clinic work was what I call organizational care work, or work for their employing organization, the work of caring for their employing organization. Because as they went through their days, I observed that these nurse practitioners really labored to smooth over the challenges and structural inefficiencies that seemed to arise without end as their employer attempted to provide comprehensive care. So these NPs became an organizational resource that could be used by their employer to address its own problems. So this was in deep contrast to their physician colleagues who did not do this kind of work either for their patients or for their employer. So I won't have time to go over the physician experience today, but I will summarize the core finding, which is that the physicians refused to be pressed into this new kind of service. The professional orientations and organizational pressures that the NPs were beholden to were neither experienced by nor responded to by the physicians. But as I observed the salience of the organizational care work that the NPs performed and that the physicians did not perform, I really had to sort of stop and consider why it was that the complex needs of patients seemed to arrive in the medical exam room rather than, say, in the office of the social worker. Because, this site's patients were certainly medically complex, but a key part of that complexity was produced by social instability. So I wondered, how did it come to make organizational sense for patients, clinical staff, and administrators to bring social and organizational problems to the clinic? So for me, analytically, it was really through comparing the work of the NP and the social worker that I came to see that the expanded work of nurses inside the exam room was related to the contraction of work outside of it. That there is, in fact, a necessary relationship between the NP who attends to the complex problems that patients bring inside the exam room and the abdication of state responsibility for addressing those concerns outside of it. So these findings are grounded in ethnographic data from a community-based healthcare organization at a site that I call Forest Grove. So Forest Grove is a long-term care organization. It provides comprehensive care to an outpatient older adult population. Its goal is to help medically frail older adults remain in the community. And how it did that was to provide comprehensive care. So comprehensive means they provided medical care, skilled nursing care, PT, OT. The clinic itself was housed within a larger adult day center that provided supervision, personal care, as well as recreation. Also, the Grove provided practical coordination, like scheduling outside appointments with specialists and assisting its patients with accessible transportation around the city. So it's important to highlight that these patients were not the well elderly. The Grove was essentially a nursing home diversion program, right? And the eligibility criteria were also markers of vulnerability. So first, folks had to be certified by the state as being nursing home eligible, which marked them as being medically vulnerable. All of the folks were Medicaid eligible, which marked them as economically vulnerable, i.e. they were living in poverty. The Grove had a geographically defined catchment area such that they primarily enrolled African Americans living in segregated neighborhoods, marking them as socially vulnerable. So the care of a vulnerable population is expensive. And the Grove received enhanced capitated payments from Medicare and Medicaid as part of a demonstration project to see if it could achieve cost savings through this sort of provision of comprehensive community-based care. Importantly, in order to truly demonstrate savings to the state, the Grove remained economically responsible for patient care, no matter what kind of care was required or what level of care was required. So what that meant was that even though this was a nursing home diversion program, if somebody eventually transitioned to nursing home care, the Grove still managed and paid for their care out of their monthly per patient or per capita payment. Also, lastly, an important feature is that a nursing school held the financial and administrative reins of the site. And while the school's influence was not routinely visible, it did shape one of the most distinctive features of the organization, which is that the nurse practitioner was the provider of record and the leader of the team, even though that team also contained physicians. So, just in case you haven't been paying attention, I'll just say it out loud for you. Forest Grove is a very strange site. But I want to say a few words about the utility of strange sites for people who do field work. Because although folks like me will sometimes obscure the point, none of the individuals, organizations, street corners, groups that we study are generalizable to a population of anything, right? So even the most generic organization I could have found would not have been generalizable to a population of such organizations. But what many ethnographers do claim is generalizable are the logics and social processes that we witness. So social life may be constructed to sort of state a sociological truism, but it's constructed out of a common set of materials. So when we watch its daily construction, we can get, so the argument goes, empirical purchase on these commonalities. And this is when strange cases can be uniquely useful, because the logics and social processes that might be too subtle to see in ordinary cases are often visible in exaggerated form in strange cases. So while the details of the stories we weave are unique and site-specific, the logics that make them plausible for the people living them should not be. So now that I've explained the site, I'm going to get on to some of the results. And I'm going to begin by considering what nurse practitioners do. So one way to figure out what NPs do is to ask them, and specifically to ask them what they think makes their work different from that of physicians. And so for the nurse practitioners that I spoke to at the Grove, the difference seems so obvious as to almost go without saying, but when pressed by the ethnographer, they did attempt to explain it to me. Their sentiments were summarized by the words of one NP who noted, "The nursing model is much more holistic. You're looking at the whole person. Yes, disease is part of the person, but so is their environment, so is their mentation, their spirit, so is their social environment. So I think instinctually, all of us nurses, that's how we look at these things." So for her, this holistic orientation informed how she practiced, and she elaborated what that meant at the Grove. "We're like the air traffic controller of the patients and their needs. NPs," she declared, "have really taken on that kind of responsibility. It's the nature of the profession." So as she went on to describe what she thought was unique about nursing, she tried to be diplomatic. She amended that the Grove's physicians were geriatricians, and they also had a holistic way of viewing people, which meant, quote, "They can't help but look at a patient as a system rather than just one disease process or one old lady. But still," she continued, "it's different. It just is." So all of the NPs I spoke with echoed this sentiment. But of course, what people say and what they do are not always exactly the same. If it were, I wouldn't have had to spend 17 months following people around. I could have just interviewed them over a course of a few months, but I did follow them around. And what I saw when I did so was that this difference was not just professed in words, but embodied in practice. These nurse practitioners as a collectivity opened the door of the exam room to include a much wider range of problems than either the typical physician encounters that have been documented in the literature, but also those that I could actually see from the Grove's physicians. So I want to recount one example of what opening the door to the exam room looked like. An example that features nurse practitioner Anne and her patient, Ms. Gray. So one Wednesday, I'd spent a day shadowing Anne, and as we approached late afternoon, she was taking a moment to catch up on her email and write up her notes. But as was often the case, this small reprieve was interrupted by the ringing of the phone. The caller was Susie, the oldest daughter of Ms. Gray. Susie described her mother as behaving nervously. So thinking through what might be the cause, Anne reported to Susie that she had seen Ms. Gray last week with a blood sugar level of almost 400. And for those who don't know, that's super high, that's like hospitalization high. But at the time, Anne had discovered that Ms. Gray had stopped taking her oral diabetes medication. So Anne wondered aloud whether this sudden shift in behavior might be related to her diabetes and asked, "Do you know what her blood sugar is?" Susie didn't know, but she suggested that Anne call Tanisha her younger sister because Susie had been the daughter tasked with calling Anne, but Tanisha was the one that was actually with their mother. So Anne agreed, she hung up and she called Tanisha. And from the moment the line connected, Anne could immediately hear what Susie had called nervousness. While Anne was trying to speak with Tanisha, Ms. Gray was shouting so loudly in the background that it was difficult to carry on a conversation. And although she could not hear Ms. Gray's words, the strength and the tenor of that emotion behind them was really quite unmistakable. So in spite of the chaos happening in the background, Anne began to troubleshoot what might be going on. She knew, for example, that Ms. Gray had just came home from a hospital stay, and that her routine prior to going to the hospital was that she received insulin injections at the Grove Center when she came, but on days that she didn't come, a home care nurse was dispatched from the Grove to do that work at her home. So for most folks, insulin is sort of self-administered, but many older adults struggle to do so because of cognitive decline, fading memory, or just the inability to learn something new later in life. So although Miss Gray had the support of 2 daughters, she lived by herself. So having assistance with insulin was one of the key supports that allowed this to happen. So after some back and forth with Tanisha, Anne figures out that the nursing visits were never restarted after Miss Gray returned home. So Anne ended the call by asking Tanisha to at least try to check her mother's blood sugar and to give her a call back. So while Anne waited for this new information, she did not return to her email or to her charting. She continued with the case of Miss Gray. I watched her send off an email to the Grove's home care department. This email was only the first in a multi-step process of both finding out why the nursing visits were not restarted and attending to the problem at hand by arranging for a nurse to make a home visit to Miss Gray before the day's end. Anne's response to Miss Gray's problem was an example of how the NPs lived out their descriptions of holistic practice within the context of an organization like the Grove. So the nurse practitioner's availability to patients by phone exemplified the ways in which they collapsed time and space to attend to patient needs as they appeared, not just in exam rooms, but inside homes and through the voiced concerns of adult children. By centering patient problems as they defined them, these NPs were in effect bringing care work into a space where only medical work is usually performed. Their openness to responding to these concerns was not only useful for short-term problem solving, it was also how they set the stage for longer-term management. Because this openness to unfiltered complaints from patients and their families was in fact constitutive of NP expertise. Right? Because in the context of troubleshooting a medical problem, for example, Anne found herself inside long-standing family dynamics through which she learned just a little bit more about each daughter's relationship to their mother. She also found herself developing a better understanding of the communication problems between the clinic and the home care department. And it was through this openness to information that the NPs genuinely became the resident experts of the Grove's patients. So among elder care professionals, there's a saying, the best long-term care insurance is a daughter. And this is really indicative of the fact that even with Medicare and Medicaid paying for services, the work of navigating bureaucracies, coordinating services, and knitting together complex information is still someone's job. Yet for many, these unpaid idealized daughters are in fact in short supply. And for many of the Grove's patients, the Grove itself had become an organizational daughter. But how good a daughter it proved to be seemed to depend largely on the work of the nurse practitioner, to the extent that coordination happened through NP expertise, demonstrating that the performance of care work for these patients was every bit as consequential as medical work. And this was particularly visible at the Grove because its entire mission was predicated on the proposition that providing comprehensive care would lower overall costs. But in providing this comprehensive care, it's really important for me to draw something out, which is that the Grove was never intended to replace unpaid family care. The economic rationale of providing coordination and increased direct services is that it would better enable family members to continue providing unpaid care rather than relying on more expensive forms of state-funded care, right? So the Grove's model economically relied on its ability to not only deploy organizational resources, but family resources. So when the nurse practitioners responded, like Anne did to Tanisha, to family concerns, right, which often included dealing with the Grove's own inefficiencies, such as the lapse of home care services for Ms. Gray, they were in fact helping to keep a patient's personal network of survival active. Because when the unpaid care of family members no longer sufficed, patients transitioned to higher forms of care, the highest and the most expensive form being the nursing home. So in putting out organizational fires, these NPs were addressing the day-to-day solvency of the organization and helping the Grove demonstrate its utility to the state. So before I end, I want to spend a few minutes talking about the social workers, in part because for me, they were really the surprise actors in this account. I did not go to the Grove interested in social work. I was interested in the medical workplace, and social work is not medical work. But for me, it was really through attention to their position at the Grove that I came to understand the relationship between the expansion of nursing's domain of work and the contraction of that of social work. Because as I watched the NPs put out organizational fires, it seemed pretty plain to me that some of what they took on from inside the clinic might have been done by a social worker outside of it. And unlike most outpatient organizations in the US, the Grove actually had social workers, licensed, master's trained social workers. Moreover, the Grove's sort of focus on coordination and management really made it seem like an ideal setting to showcase social work's expertise. But I observed that the doors of legitimacy were often closed to the Grove social workers, and no one knew this better than the social workers themselves. Social work gets no respect, was one social worker's assessment. And while her work with patients was challenging, this complaint was not about patient care. It was really an expression of her feeling that she and the other social workers undeservedly occupied the bottom rung in the Grove's hierarchy. And to be honest, they were absolutely right. A range of staff expressed open dissatisfaction with the department. And this went beyond the sort of closed door terrain of whispers and gossip, really. The problem with social work had become an organizational fact of which everyone was aware. In explaining this fact, most staff relied on individual level theories, that there was something wrong with these social workers. And while some were more sympathetic than others, no one thought they were doing a good job. And here lay the conundrum. The Grove social workers were also well aware that they were not doing a good job, right? i.e., they knew they weren't doing the kind of work that they had been trained to do. But while others located the fault within the department, the social workers themselves located the problem within the priorities of the organization. They believed that the work of the clinic was supported in ways that their work was not. And it wasn't that anyone at the Grove discounted the need for their services, because again, this was a vulnerable population. Everyone knew that a kind of attention to social problems was actually really important. But the Grove, when faced with client vulnerability, their default organizational response had been to invest in the expansion of the clinic rather than in social work. So these teams, right, were sort of anchored by a full-time nurse practitioner, but this full-time NP had the support of a full-time registered nurse. And over the length of my field work, they added the assistance of a part-time nurse practitioner to help each team. And this was in addition to the physicians, right? Yet over the same length of time, I observed that there was usually only one social worker to cover the case management needs of the same number of patients. So the social workers were keenly aware of how these constraints affected their work. As one of the social workers told me, with over 100 clients, it's really hard to get intimately involved. You lose a lot. I heard the same thing from an intern, a social work intern. I interviewed her about 4 months into her tenure at the Grove, but she felt like she had already been there long enough to know what the problem was. Real social work, she told me, is impossible. Because of high caseloads, the only thing she felt like she had time to do was to make sure the patient is surviving and has basic needs. For her, social work at the Grove was all surface work. So in the face of organizational disinvestment, it seemed that the social workers themselves had disinvested in their traditional realms of expertise. And instead, they attended to the work that their colleagues may not have valued, but that the Grove's structural and economic logics incentivized. And that was paperwork. So as part of my fieldwork, I attended a range of meetings, including that of the social work department. And at one of these meetings, the social work supervisor was engaged in the department in a conversation about what to do for Social Work Month. So she asked the social workers to think about ideas that would pick up our visibility, something that would really push our work out to the staff. She seemed, in my estimation, to be marshaling a kind of public relations campaign for the department. So in response to this question, one of the social workers wondered aloud, how can we let the staff know what we spend our time doing? So over the next few minutes of discussion, one suggestion in particular captured their collective imagination. Forms. Why don't we count up how many 1372 forms we do in a month and display it like on a bulletin board? So Form 1372 had to be completed anytime there was a change in a client's program status. So what they joined or withdrew from the Grove, changed residence, moved in and out of a nursing home, whether short-term or long-term, or they died. Anytime this happened, this form had to be filled out by a social worker. And completing this form accurately generated a cascading set of tasks. They had to document new and old addresses. They had to secure medical documentation and fax them back and forth. They had to make a bunch of phone calls. But it was really important. This work of filling out the form was very, very important to keep the Grove in the good economic graces of the state, because accurately documenting where patients were on a day-to-day basis was really largely about reporting to state and federal entities where the money should go. Medicaid, Medicare, and Social Security payments are all based in part on where people are. So this importance to the state and then to the Grove had filtered down to how the social workers conceived of their work. The filling out of forms had become a meaningful visual representation of how they spent their time. And much of the actual labor that social workers could have performed was unaccounted for through this paperwork. As the social workers themselves had noted, there seemed little space left for the doing of real social work. Paperwork was all that was left. The social workers' dissatisfaction, however, really went beyond their individual conditions of work. They also expressed to me an existential critique that could really be applied to the entire state of the profession. One social worker opined to me, "The profession of social work is about empowering people and communities. You don't hear very much about that around here." So when these social workers talked about empowerment, I was familiar with the story they were referencing. Professional social work began in the settlement house movement of the early 20th century, which was in contrast to traditional forms of charity, because settlement workers lived within the communities they wished to help. And yes, they provided direct services, but they also stood alongside residents as they sort of advocated for social change. So when the Grove social workers linked their profession with client empowerment, the settlement house tradition is one part of their history that they're in conversation with. But this view of empowerment is really difficult to carry out in an organization when you're not working with a community, but with patients, and where the logic of medical care reimbursement makes some work visible and hides others. Because underneath these social workers' assessments, I found a more general critique. The primary reason they were working at the Grove was because healthcare is where the money is, not social welfare. Because while the federal government may not directly provide most of our nation's medical care, it does pay for a good deal of it, 70% of long-term care and 50% of total care, which makes this really less a problem about scarcity and demand than a story about the privatization of state resources. And the reality is that these resources are going to some locations and not others. Because at the same time that the state has invested in healthcare, it has disinvested in social welfare. There's a shrinking budget for public education, for anti-poverty programs, and for the traditional domains of social work that these workers would have preferred to be employed. But there is money to pay for healthcare, including the expanding domain of work provided by the nurse practitioner. So in conclusion, the Grove hired its nurse practitioners for their medical expertise, but in practice, it deployed them as more than substitute physicians. In addition to the mandates of medical work, they held their nurse practitioners uniquely responsible for a broader set of responsibilities that went beyond medicine. But I also came to understand these NPs were often laboring to do was to fashion individual clinical safety nets in lieu of one crafted by the state. So I'll end by suggesting that maybe it's time to ask ourselves a different set of questions than the ones that came out of the healthcare crises of the 1960s, such as, what if, when faced with physician scarcity and rising costs, the state had declared healthcare a public rather than a private good and matched the weight of its financial investment with a more cohesive healthcare policy? And what if the state had invested in the social welfare realm to address the worst excesses of poverty? What if the state had stood behind the value of fairness and social justice and chose to invest in communities through supporting public education or enforcing things like anti-discrimination laws and public accommodations like housing? But that isn't the choice the state made then, and it isn't the one it's making now. And as a result, for many, the only safety net they have is healthcare. And so much of that work becomes the work of nurses, not because they're especially heroic, but because they're the ones in the room. So in my book, I focused on the ways in which nurse practitioners specifically meet these needs by being the ones in the room as physicians continue to absent themselves from primary care. But in my study, Caring in Crisis, I'm seeing how bedside nurses are also doing something similar. So speaking as a patient, I'm glad that so many nurses are choosing to stay in the room. But the nurses that I've interviewed suggest that many are losing their ability to do so. But there's also something else to consider here. So although I'm focused on the work of nurse practitioners, we should also consider the terrain upon which they work, the Black, brown, and disabled bodies of those who qualify for public insurance, because those are the patients that nurse practitioners collectively are disproportionately hired to see. And when I saw them working alongside their physician and social work colleagues, what I saw was not conflict with one another, but the existential conflict that arose for all of them when they found themselves working in a system that treats healthcare as a territory of capitalist extraction, a system that not only extracts value from the labor of workers, but from the Black and brown bodies of the sick, bodies which we are told have no value at all, or that are even supposedly a drain on our resources, until they are turned into commodities in our quasi-privatized healthcare system. I saw that in my work for the book, and we can see it in the pandemic, right? So that as patients and providers suffer, folks with a financial stake in our commodified healthcare system have, as the young people at least used to say, made bank. So I'll close by saying that I think we should question the policy narrative that always suggests that we are broke in the face of escalating healthcare costs, and that instead we should consider the ways in which the medical workplace is a productive space, one that produces tremendous economic value for those with a financial stake in the system, but also one that is actively implicated in the production of social inequality. And who, we might ask, is the stakeholder for that? So thank you so much for listening to me, and I really look forward to hearing your questions.
Thanks for a wonderful talk, LaTanya. So if you have questions, please type them into the Q&A. I'll let Amy sort of take over with the Q&A if that works for you. If it doesn't.
Great. Sorry about that. We had an overhead announcement here. Great. So LaTanya, thank you so much. That was such a fantastic talk. So I would actually like to start off with a question. You seem to sort of throw down the gauntlet with some pretty specific critiques of the way that healthcare is managed in the United States, and certainly not a critique of nurses themselves, but a critique of the way that the system has established nursing as the front line. If you could wave a magic wand, what would your solution be, to fixing this issue?
Would it be flippant to say a revolution? That's partly a facetious answer, but it's also really a real one, because partly, I featured the work of nurses in this talk, but most of this evidence really comes out of looking at the long-term care space, right? I've previously thought about, the sort of rallying cry of having a single payer system. And I think that there are many arguments to be made for the value of a single payer system. But long-term care is really close to being a single payer system, right? 70% of the costs of long-term care are borne by the federal government. And yet, right, there are still tremendous amounts of inequality in terms of how they fund and who they fund, in terms of the kinds of care and the kinds of healthcare organizations. And so I think that on one hand, the easy answer would be to say, we really need to sort of deprivatize this healthcare system, in part because the things that aren't working well because profit is being extracted. And there's really just no way of getting around the fact that the profit mode of this sort of extraction of value from both workers and patients is a fundamental part of the system that cannot really be fixed with, an ameliorative fix here or there. But I also think that we have to sort of ask, much larger questions, because as I sort of, watch these NPs and of a range of different providers, so much of what they were doing was not just the provision of medical care, right? And I think, to simply fix medical care without addressing the fact that we are not supporting sort of social welfare policies, that we are not supporting things that we might consider to be in the realm of social justice, but I might think of as just being in the realm of fairness, establishing fairness for folks living in the U.S. I think that really has to be addressed, and I don't think that there are any amelioratory fixes for those, because in fact the system isn't broken. It's working perfectly well for the people who are making money from it, right? And those are the people that are in the sort of, halls of power, those are the people that are lobbying. And there's no military fix for that, So although I was being facetious by saying revolution, I think we have to actually have a radical transformation in our thinking about what the role of the state is, and what the role is of private money-making entities when we're thinking about the sort of fixing of these kinds of problems.
Great, thank you. And as just a quick follow-up, how do you think that your findings are shaped by the fact that it was an elder care healthcare setting rather than, and particularly one, right, dealing with with a population that had so many social economic vulnerabilities?
I mean, I think that there are ways in which, it may have been shaped in ways that I don't see. Because frankly, if I saw it, I tried to fix it, or I tried to not make a comment about it because I didn't think my data could speak to it. But I think, again, this is sort of related in some ways to my previous response, which is that I was collecting data in a site that was the best possible situation for everybody, right? I kind of got a little bit jealous watching the sort of array of resources that were available to the sort of population of people. I kind of got a little bit jealous watching the way that the nurse practitioners sort of paid so much close attention to listening to the concerns and needs of their patients, not just because they were good people, but in part because they had a sort of professional existential orientation for listening, but also because they had resources. Like they literally could fix some of these problems because they actually had resources. If I had been in normal medical care land, nurse practitioners don't always have, or any kind of provider doesn't have these kinds of resources. They don't have social workers. They don't have PT and OT that they can just refer to their patients, in-house, as opposed to trying to navigate outside spaces. So in some ways it clarified that in a context in which in some ways everything was going well, right? To still sort of see the ways in which the sort of construction of these problems and the sort of fixing of these problems was shaped in particular ways.
Great, thank you. So we've got a question from Ann Bostrom. She says, fantastic talk, thank you. Can you comment on whether there are meaningful variations in long-term care that might A, ameliorate the problems you saw, and B, inform ways of improving the system?
It's difficult in some ways perhaps for me to speak about the variation, in part because I didn't see it in long-term care because I was really sort of focused on the site. I could certainly, see the ways in which many of the patients sort of came out of other kinds of institutions and organizations, the kinds of difficulties that they often had navigating them. And I really do think that there is this sort of, this idea of comprehensive care, this idea of paying attention to the sort of whole person in a structural way. We're not just in a sort of with words. Everybody says whole person care. Who doesn't support whole person care? Like who are these people who hate whole person care? Everybody loves it, but we often don't actually sort of embed that value within the ways in which organizations are organized. I think the other thing too, I think, really comes down to what is being paid for. Because again, there was something, because it was kind of the best possible world, the growth sort of economic foundation. But one of the things that you sort of see in long-term care is you don't actually see this kind of economic foundation. And in particular, right, so I'm focused in on the sort of value of care work for folks, and really thinking about the ways in which, in this organization, because everything came to the clinic, the NPs were doing a lot of that work. But again, I think some of that could have been done by other people. And I think in other places, home healthcare aides are fulfilling that function. Example for folks, and I think that they don't get paid right? I mean, in some ways, it's very similar to the social workers, which is that they're not economically incentivized to provide this kind of whole person care that everybody says that they want. And what was unique about the NPs is because essentially they were providing medically reimbursed care, right? And then but padding a whole bunch of other stuff around it so that it was ostensibly paid for, right, as a part of the medical visit, as opposed to having to find the payer to pay more for the home care worker or pay more for the social work services. So I think, part of that variation, I mean, again, the fact that this organization was relatively well funded shows how underfunded the rest of long-term care actually is. You have older adults who are on wait lists to receive home health care services that someone has deemed are medically necessary, but they're waiting a year to get it. How does something be deemed medically necessary, but you can't have it? Right? There are these kinds of things that happen in the sort of everyday lives of folks receiving long-term care services.
Great, thanks. And then I think Jenny Romick has a question that she wants to ask live. Uh-oh, Peter, is she unmuted?
Jenny, you might have to unmute yourself.
Hello, hi. Thank you. I am a social work professor, and I really appreciate your talk and your analysis here. And in part, I think you just started answering my question. I should say I'm a policy professor, so I talk to my students about why we need revolution and stop extracting profit from social systems, rather than actually teach people to be things like medical social workers. But I was struck as you were explaining a lot of what the nurse practitioners do, that's stuff that social workers are also trained to do. And very crassly, they probably are cheaper than nurse practitioners. And I'm wondering why, in your sense, did the social workers not have more of a role in addressing some of the family dynamics and social setting things that were clearly contributing to folks' health and well-being? Is it just easier to locate it in one primary care provider, or what? So, and I'll go back on mute. Thanks.
I mean, thanks for your question. Because I mean, it is the question of, that really sort of motivated. I mean, if you see my book, it's divided into thirds: the NP, the physicians, and the social workers. So I actually spent a lot of time talking about the sort of experience and position of the social workers, because it's true. Much of what the NP did, much of what the NPs did, could have been done by a social worker. And I had to really account for the ways in which they weren't being done by social workers. Really, part of it was that, my observation was that, what happens at the macro level was happening at the micro level. At the macro level, there's no payer for social work services, right? That's what happens at the macro level. And when you dive into the scenario of the Grove, and you realize that, on one hand, they were required to have social workers, right? Credentialed, licensed social workers be there. But, they didn't bill in quite the same way as the medical providers did. And so honestly, what was happening, right, was that, the money was driving people's perspective on what was actually a value. Like, when sometimes you don't really understand or see something until you summarize it even for yourself. The fact that the medical team had a full-time NP, a full-time RN, a part-time NP, and physicians, and one social worker for the same patient population, right? Obviously, there is a mismatch in terms of the investment of resources. So in part, the nurse practitioners had the ability to solve some of these problems, in part because they had more time, because their work had been invested in, the work of the clinic was invested in. So I think one of the things too that might help this to make more sense is that as the ethnographer, I believe that I uncovered this sort of extra work that NPs did, right? I don't think anybody knew, right? Or it wasn't written up in the job description, because really the job description of NPs is do the work of physicians, but just do it cheaper. That's the job description of the nurse practitioner, right? No one expects them to do difference. They're not being paid to do difference. They're being paid to do same. So this difference is something that is invisible, and yet it's happening. So their work gets reimbursed at this sort of higher payment level because it's classified as medical work, whereas the work of social workers, even in this site that what kind of outpatient sites have social workers? Very, very few, right? This site had social workers, but even in a place where there were resources being given to social workers, it was much, much, much less than the kinds of resources that were being given to medical providers. So yes, I think the social worker would have been cheaper, but in part the NPs were doing invisible work. And perhaps if it had been visible and coded, people would say, the economics of this don't make sense, right? But they weren't doing it that way. It was really largely invisible work.
Great, and we've got time for one last question. This comes from Mary Waters, and she says, this was so interesting. I know this is probably hard to say, but what would you say are some of the examples of other countries that have better systems of healthcare or long-term care, meaning better for both workers and for patients?
I mean, I'm not an expert in this area, so I'll preface it by saying that, because in some ways I'm going to list the usual suspects, right? I think that countries where state payment is matched by state oversight are the kinds of places in which I think this works better. Because I think partly this is being caused, right, by the fact that essentially the government is funding a source of money making, right? And so these things cannot actually, you can't both make money, right, and sort of maximize your resources for the sort of health and well-being. So I think, looking at the Nordic country, the sort of social welfare state, and I think particularly, the social democratic states are probably the best example, because they also have a robust social welfare system. It's not just a robust medical system, it's a robust everything else system as well. And again, I think that lowers the costs, right? Because you essentially have very expensive people whose issues might have potentially been addressed in some other realm, right, through sort of social welfare policy or through political policy, and instead they end up, in exam rooms, right, where people are making money off of the sort of production and appearance of these problems, but no one's making money off of that in places where the state that pays is the same as the state that controls. So that would be my answer to the question.
Okay, thank you, LaTanya, for giving such a fantastic talk. That was really wonderful. I really enjoyed it. Join us next week when our own John Wakefield gives a talk on his research. Have a great weekend, everyone.